Welcome to the Living Medicine podcast, where we talk about ethical medical use of psychedelic psychotherapy, teaching skills, examining the issues, and interviewing interesting people. Now let's start today's show. Hi, and welcome to Living Medicine. This is Signe. Today we have a really special episode where Sandy got a chance to interview Mel Herbert. Mel Herbert is the leading speaker and educator in the field of emergency medicine, and has also taken on a sort of prominent role in educating other medical specialties as well. And he started out educating people on medicine itself, but really lately has moved into focusing on this growing problem of physician burnout. And so he is a prominent voice in speaking to that, and was willing to get on to speak to Sandy about his own personal mental health struggles and his benefit from ketamine-assisted psychotherapy. So we're really honored to be speaking to him today and for his willingness to share his story with Sandy. So without further ado, here's Mel Herbert.
My name is Mel Herbert. I am a physician, emergency physician, who trained in Australia first and then in the United States. And I'm the CEO of MRAP, which is an education program that goes out to about 65,000 people across the world, mostly docs, but also docs and nurses.
And I am Sandy Newis. I am a psychologist in Asheville, North Carolina, and I am the co-founder of the Living Medicine Institute, which is a training, resource, and content-based program for clinical and medical professionals who are interested in learning about ketamine-assisted psychotherapy and psychedelic medicine in general. And we also have a sister program called Concierge Medicine and Psychiatry. That is a program that does ketamine-assisted psychotherapy and ketamine treatment for people with underlying mental health issues. So I'm honored to be here with you, Mel. Yeah, this is really exciting.
Yeah, we've been sort of chatting back and forth and like, we should do a podcast. And I need a podcast and you need a podcast. So we're going to take this podcast and chop it up in a different ways. So if you think you've heard it before, you might have.
Right. Great. Well, I have been following you on social media for a while. I've been really interested in what you all did with MRAP. But what I think really brought us together ultimately was good timing on my part, where you had just experienced some benefits of ketamine treatment yourself. And I was hoping that you might share about that, like what led you to that and kind of where were you before you started and how about why ketamine?
Why ketamine? Yeah. So what led me to ketamine was the usual failed other therapies and then got to ketamine. So I had an episode of depression as a kid when I was about 13 or 14. And then I got busy with medicine and I was too busy to get depressed. So I've been obsessive for the last 40 plus years. And then I had another episode and it was quite severe. And I have a great primary care doc and we tried SSRIs and they didn't work, as is the case, 50% of the time. Lots of side effects, didn't really work. And then we changed to a combined norepinephrine SSRI agent. And then I became actively suicidal.
Oh, interesting.
And it's a little bit humorous in that she told me, like, one of the side effects, Mel, is 1 in 20 people become actively suicidal. If that happens, call me. We'll get you off it as soon as we can. And I started to become actively suicidal. But I'm like, it'll be fine. It'll go away.
Right. I know what this is. They told me this would happen.
Yeah, I'm a doctor. What could go wrong here?
Right.
And it was actually my wife, when I was at the lowest ebbs, like, what the hell is going on? And I asked her, do you mind if I kill myself? It's sort of a very matter-of-fact thing. Just asking permission. Please, is it okay? And she's like, what the fuck are you talking about?
Right. Are you serious? Are you actually meaning? Yeah.
And I meant it. I was just so depressed, but it was sort of, it had gotten to this matter-of-fact thing. Oh, the only way I'm going to get rid of this is if I die. Yeah. So thankfully, she is the woman that she's like, oh, I don't think so. And dragged me down to see the dog. And we had a nice intervention there. And then she said, like, I got this group at UCLA doing ketamine. We'd actually spoken about ketamine before I started therapy. And so then I got into this program and it was magic, actually. I mean, it really changed my brain is the only way I can explain it. And I know that there's all of this stuff about neuroplasticity and changing pathways and doing ketamine. And if you're doing therapy at the same time, you really can change the way your neurons fire. And for me, that was absolutely the case. That was, I don't know, 8 months ago. I did 6 sessions a week apart with therapy before, after, still doing it once a week. I
Yeah.
then
Same
had,
therapist?
pardon?
Same therapist?
Same therapist
Great.
who is awesome.
Nice.
So insightful, amazing woman. And with a physician as well. So in their program, you have a physician and a therapist in the room. The
Yeah.
physician looks after the physician things. The therapist looks after the therapist things. Really great team. And then I did 2 more a few months later, 2 more
Yeah.
sessions a few months later. And that was about, 6 months ago now. And I keep waking up every morning for the penny to drop, because I wake up every morning and I have not felt this good in decades. Like, I'm excited about being alive. I'm so grateful to be a human. I really, when I start the day and do my work, and it really has changed my brain. But like I say, I keep thinking, when is this going to wear off? And we've talked about, it's like, if it wears off, we'll do it again. But right now, I'm in that place where I'm just so thankful for this therapy. And a lot of people ask, why are you so open about talking about your mental health? And it's like, because in my profession, I'm a leader. And in emergency medicine, we're in a crisis. Our docs are depressed. They have PTSD. They are dying by suicide at a rate greater than it's ever has been. It is a real crisis. And I joke, yoga's great, but we've got bigger effing issues than yoga right now. We need other therapies. So that's why I want to talk about it, so that those people out there, well, let's take some of the stigma away from this, and let's understand that we've got these therapies that we should have had for a long time, but we stopped studying them 30 years ago.
Right.
And now we're studying them again and we're using them again. And they're profound as long as they are done, in my opinion, with the right therapy group. Somebody like you.
Yeah. Well, thank you. I mean, it's interesting because I've mentioned it, but I've since gotten a little bit more of the story. Is my co-founder, my business partner, Dr. Signe Goldman, her husband, Dr. Maydock Goldman, was an ER doc. And he actually gravitated towards co-opening a ketamine clinic with her because of really moral injury that he experienced as an ER doc, as the medical system became, bought out by the large corporates, and the dilemmas, the sort of professional and personal ethics that he felt like was compromising, and just the increased stressors and just all of it. And, so he would concur. Just like, and so, bringing this to light as, taking away the stigma, and that it can really help with that PTSD and recalibrate your brain and your nervous system after decades of that kind of chronic stress, is really important.
Yeah, it's a particularly difficult time. ER docs and nurses and paramedics, they suffer a constant amount of PTSD. I mean, there literally are people dying on every shift, children who are injured. That's the baseline.
Yeah.
And that's hard. That's so difficult. And then, as you say, now we layer on top of all of these financial things that are going on during COVID, having patients basically taking a swing at you because they didn't believe, the science, to be called liars. I had death threats because we were doing shows about COVID and how to treat it, and I was getting calls. But you're a liar. You're part of this. You're part of the system. You deserve to die. It's like, and this was happening to lots of us. So yeah, It's like stress upon stress upon stress, and it broke lots of us. It broke most of us. In fact, I tell this story, and it used to be shocking, but it's not anymore. We did, in our residency about 10 years ago, we asked anonymously to the residents, about 60 residents, are you depressed? Do you have any suicidal ideation? And a third of our residents had suicidal ideation on a daily basis.
Third. That's so intense.
And I'm sure it's worse now. During COVID, the residents were in serious trouble. And now the whole profession is feeling it. So this is to say that this mental health crisis feels like it's affecting about 100% of the docs I talk to. And I talk to a lot of them. It feels like every one of them. And it's just about the degree to which they're suffering. And I can tell you, since I've started talking about ketamine in my book and on podcasts, I've had just an overwhelming number of people saying, tell me more. Where do I go? How does this work? Should I just go to any random person down the street? Should I do it on the couch by myself? And my answer to that is find a reputable group and go interview them, go talk to them, and start now. Do not start doing ketamine poppers on the couch by yourself. This is not a good idea. Have a guide.
Not.
You need a guide.
Right. Yeah. Well, and it's interesting because, people don't realize, or maybe some do, the listeners, that ketamine is really completely unregulated. So anybody who is a prescriber can get a controlled substance license. And, as long as they have kind of, their ducks in a row, they can open a clinic. And ketamine-assisted psychotherapy providers, there's also no regulations for training. So it's really up to the consumer to understand that there are significant differences in the setting, in the guidance that you receive, in the way that, the professionals work with you. It's not just about the medicine itself. And I think that's really just of critical importance for people to understand. I'm curious if you can speak to that kind of, because there's the pharmaceutical effect of ketamine, which can have a profound effect. And some people just do ketamine alone and whoosh, the fogs lift and that's it. But that therapeutic component, we believe, is really important for many people, if not all, but certainly many, especially if we're looking at chronic stress, PTSD, effects on the nervous system, often go back to childhood stuff. Yeah.
Yeah, for me, I couldn't imagine not doing it with a guide, a therapist, because your brain does get into this plastic state.
Yeah.
And I don't know how you would reform those pathways the right way if you don't have somebody to help you. So for me, it was a lot of childhood trauma, abusive father, alcoholic mother, 5 kids, and one of them's in a federal penitentiary, and the other 4 are drug abusers and alcoholics, and we're all a freaking mess. So it all goes back to that. So just doing ketamine might be a nice experience, but I needed to work through that stress. And then I needed to work through all of the terrible things I've seen for the last 40 years that still I have these flashbacks, just like in war. I still see the dying children over and over again. And really had somebody to help heal my ego and my psyche.
Yeah.
And the ketamine was an adjunct to that. That had to occur, but the ketamine really helped me get that insight and that plasticity. So I really think it's a bad idea to do this without having a therapist there to help you through it. There's a lot to work through. It's not a magic pill. It's not just like, ta-da, magic, you're fixed now. That'd be awesome.
Yeah, right.
It doesn't work like that. It for the vast majority of people. And if we think back, to the shaman, they would take you up into the hills 10,000 years ago, and they'd basically give you therapy and then give you psilocybin. It was very similar. But you have to have that guide. And for me, what I want going forward is to never go through that again. That was very dangerous. As my wife says, nobody died, but boy, it could have gone badly. And I want to have a team to.
Yeah. Sorry, I didn't interrupt. But when you get to where like, hey, what do you think if I were to just kill myself? Like as if that seems like a viable option, which is what people don't realize about suicidality. Like it's when you begin to entertain that as if that is like a reasonable idea. Like,
well, it becomes a reasonable idea because you believe that you would be better off, but also really importantly, everybody else would be better off if you were dead. That's the lie that your brain starts telling you. And I've had friends and colleagues die by suicide, too many to count, sadly. And I just could never understand it until I got there myself. I'm like, this is what you were feeling. You were feeling that the world would just be better if you were gone, and you would feel better if you were gone. And that's such a dangerous place to be because it's a lie. It's not true, but you're absolutely convinced of it.
Yeah. Well, and I love that you're saying that because I think, there's so much stigma for mental health. And, I think doctors in particular, like you're trained to be the ultimate authority. So just as you said, oh, I got this, like, oh, that's what this is. Like, we'll just analyze these symptoms and, not recognizing the chronicity of the stress that goes along with that. And then how that's going to impact your nervous system. It's like being in a persistent war zone over and over and over again, that you have to be prepared for, an indeterminate amount of suffering and pain and then whatever kind of administrative stressors come from the setting itself. So.
Yeah, and physicians, die by suicide, at an extraordinarily high rate because like as you said, we're told that we're supposed to have our shit together. Right. We're not the patient. We don't get sick.
Right.
We're supposed to be in charge here. And it's really hard for physicians to go and ask for help. It's like it becomes this, I must be the only doctor that feels like this. Because
Right.
look at all these doctors, they're in charge and they're always in charge of the team.
Yeah.
So again, to say to these people, no, you're a human. You didn't get
Yeah.
not to be human just because you went to med school and worked really hard for a long time. You're human, and we're all suffering from this.
Right. And I think something that people don't realize about that kind of a trauma response is that it's really physiological. I mean, it is attached into the survival part of your brain and your nervous system. So it's not, it bypasses any real psychological issue. It shows up as psychological, but it's not a personality flaw. It's a biological response to chronic life threatening stress that, in the case of physicians, especially ER docs, is very real life-threatening stress. And so your brain is just doing its good job to keep you in this state of hypervigilance. But then we put that state onto things that are in front of us, and we begin to interact with our life as though everything is a life-threatening event. So treatment isn't about processing the content. That's a little bit about it, but it's really, like you said, it's about adjusting your brain and your nervous system to be able to feel safe and allow a sense of well-being to settle in as your norm.
Yeah, it's so true. Like after shifts, it's so difficult to come down because of that adrenaline.
Yeah.
And some people don't, and there's a lot of alcohol use. It's that's sort of the preferred drug by most ER docs. They're like, I'll just go home and I'll have a glass or 7 of wine to calm
Yes.
down. And it's a terrible drug.
Yeah.
I mean, it's in small doses, it's great. It's a great sociologic drug. But to
Yeah.
treat the symptoms, it's terrible. It has a poor side effect profile. It has a short-term effect, which then exacerbates the underlying condition. So as a drug, it's like, this is not the right drug to be doing. But
Right.
it is. But if you've just gone off one hard shift and you've got another hard shift, and then you're doing night shift, then day shift, then night shift, then day shift, it's been shift work alone is sort of the cardiovascular equivalent of 2 packs of cigarettes a day. So you've
Oh,
got
yeah.
all of these physiological stresses.
Right.
It's no wonder this profession is in trouble.
Yeah. I mean, I have physician friends who have families, they have homes, they have families, they have lives, they work, somewhat regular hours, and then bam, they're on call for 4 days, and they just like work around the clock, and they're just expected to do like life-saving, life-threatening things. And then and then come back and just be like, pick it up and be like, hello, children, hello, family, and no sleep. And as if that's just normal. I certainly don't have the solution to that, but I've often marveled at just that phenomenon, what that must do to people's, you know, functioning in so many levels.
Yeah, there is some solutions to that. A lot of groups don't do it. Part of the solution, and I knew this when I was a resident in training at UCLA. I remember turning to the residency director in my last year, like, I'm not going to be able to do this past 50. That was when I was
Right.
in my late 20s. Like,
Yep.
I need to, and he was a sort of finance guy. I'm like, tell me how
Mm.
you save for retirement, because there's no way I'm going to be able to do this when
Right.
I'm in my 60s and 70s. No way, physiologically, not going to happen. And I retired at 50
Yeah.
for all of those reasons. Like, it's
Yeah.
hard to do night shifts when you're 30. Try it when you're 50. Try it when you're
Seriously.
60. Your body's just
Right.
like, I don't think so.
Yeah. Yeah. And you can't think. I mean, that need to make those fast decisions on your feet, like life-threatening decisions, and the constantness of that. So I just have a lot of compassion for that. And I hope that, this and other things at least kind of help physicians see the need to, I call it tending your nervous system, right? To like
Mhm.
get the care and the support that you need to tend it. And I think ketamine and ketamine-assisted psychotherapy can be amazing for that, because it can happen fast, and it can happen in really profound ways, and it can really shift your perception. So I was wondering if we could go back to your experience for a minute and talk about
Mhm.
what is it actually like to be in the medicine, and then, it sounds like you had a therapist with you, and to also be in the care of somebody else while in that. Because a lot of people think ketamine is just like inward focused and you just sit there. And really, it's, in my experience, it's much more relational than that. But I'm just curious what your experience was like. What did you see? What was it like? And then what was the experience, if there was a relational piece to that?
Mm. Well, I should say for the record, I've given ketamine to thousands of patients.
Right.
So in the ER, we use ketamine at high doses, the dissociative dose, 1.5 milligrams or higher, basically to disconnect your brain from the rest of your body while we put you back together. And we would always tell patients, like, as you're coming out, there can be very bizarre experience. I had an experience when I was practicing, but we're going to try and keep it as calm as possible, but you might be seeing pink elephants and stuff, and I don't know what goes in that K-hole space, but apparently it's pretty weird. And we would have people come out of that dissociative state screaming, terrified, in part because of where we were doing it, which was in a busy, horrible,
like bright lights, loud,
bright lights,
crazy.
flashing.
Yeah.
And they would come out and be disoriented, and then to come into an emergency department where there's vomit and all this stuff going on, like, some people came out and like, that was awesome. I'd like to do that again. But for me, we would do therapy beforehand and talk about what maybe things that I needed to explore that day.
Yeah.
And then lie on a really comfy couch and put on some eye shades and a really comfy blanket and some really nice low music on the side.
Yeah.
And then I would be sent off into the K-hole. And I was instructed that if I needed to say anything or needed to be held or whatever it was, that the therapist was going to be there the whole time. And for me, I didn't need that. I was just experiencing the ketamine effect. And then when I came out, that was a very powerful time. As that started to wear off and I was coming back to the real world, I call it the donut world because my wife would always bring me donuts after we did ketamine. I'm like, I'm going back to the donut world now. That's when we really did a lot of great therapy where I was still disinhibited and able to really talk. It was that time. So the ketamine hadn't worn off, but I was very disinhibited, but now back in the real world, able to talk. And we really did some deep work during those short periods of time. And then I'd spend the next week thinking about those, journaling about it, and then come back the next week. I will say that the first time I did ketamine, I got quite scared because it's really hard to describe what it's like, but it's like a Nolan movie. I'm out in space, floating around, separate from this universe, but part of the whole universe. And it's a very strange sensation. But the first time I started to get panics, like, will I be able to get back to the real world? I don't know how to get back to the real world. Like, it was something I would have to do. I'd have to find the door out in space to find my way. So I was a little bit panicked. We talked about it beforehand, and my therapist said, this is really common. Don't worry, the drug will wear off and you'll just magically come back. And that happened. And then so after that, that fear had gone. So I was just able to come out without fear and just like be in that sort of semi-dissociated state and be able to do therapy at that point as well.
Yeah, good. And for us, we often work with that as just being part of the parallel process, right? Like kind of noticing what happens when you face fear and what happens. And we use what is called tethering, where we kind of sometimes we make our presence more known, than others and, actually help people come back from that. So,
how do you decide the dosing? So we started pretty low. Again, we use a lot of ketamine now in the ER. Low dose subdissociative for pain. It's a really great tool for treating pain with or without other pain medications. And we usually use like 0.2 milligrams per kilogram. What do you usually start your patients on? What kind of dosing?
We start at 0.5 milligrams per kilogram, just as like your starting point to consider. So, you can do that as cut and dried. When in doubt, that's a good starting point. And we do mostly IV. So we would do IM if there was a reason, if somebody felt strongly, but we like IV because it's a nice stable state. It comes on, it stays pretty consistent, and then it wears off. And kind of that wearing off piece is the tail that you're talking about. But that dose level, and then we might adjust down if somebody's really anxious or psychologically or physiologically has a higher degree of fragility or is also just expresses a lot of nervousness. We'll call that first session to be just about understanding the medicine. And then as a therapist, I'm kind of holding on to what we'd call parallel process. Like, how might that be like other things in their life? Like, it's like legit. It's very legitimate to be concerned about, turning yourself over to this experience and in the care of others. That makes perfect sense. So normalizing that, but also really tracking the way in which those patterns might emerge in somebody's life in other ways. And that's what preparation is about. But that would be another reason that we would take into account for dosing. Now, if somebody has a lot of psychedelic experience, or, there's a number of other reasons, but we might gently bump it up. But we're rarely going to go more than just a little bit above that in the beginning, because we personally find in our clinic that getting to that sweet spot right below psycholytic, which is where you can still track what's going on, but you're still very much in an altered state, is useful for the work that we do, which is often sounds like more talking during than you did. Not that that's good or bad. There's just different camps in that.
Right.
And so that's where we start. And sometimes we bump up generally go up 5 milligram increments. Sometimes we'll go up 10 if there's a reason why we think a higher dose might be effective. And there are psychological reasons for that. And sometimes we'll, bump back down if the person got overwhelmed, if they got panicky, because you don't want somebody like that. Fear state is something to look at and something to be with. And, there's probably a degree of tolerance that can be taught around that, but that's not where we want people to land. We don't want people to like tighten up and hold on and have that just be the whole thing. Like that's not particularly therapeutically useful.
And my ketamine was IM, worked great for me. There's also oral ketamine. The doses, because of its first pass metabolism, which is a big word for it getting broken down before it gets to your brain. The doses are much higher and it's much more erratic. So I don't know really if anybody is using much oral ketamine for this type of work. So for me, it was IM and it worked great.
Right.
I want to go back to something you said, which is really important. As a control freak physician, it was really important for me to trust the therapist and to trust the process. Even though I know ketamine is incredibly safe, we have so much experience with ketamine in much bigger doses than we're talking about here, much bigger doses. It's a very safe drug. There are lots of case reports of accidental overdoses by nurses and doctors in hospitals, 10 times, 100 times a dose, and patients basically just slept for 12 hours and woke up. Very safe drug. Having said that, with any drug, you can hurt yourself. Matthew Perry is the great example. They were giving him truly massive doses of ketamine, just insanely large doses of ketamine, and then he would get in a pool of water. That is just asking to drown, and that's what happened.
Don't take really high doses of ketamine and go into water. That's a really bad idea.
By yourself while the person who injected it leaves the house.
Right.
I mean, everything about that was crazy.
It's like hard no. Like that is like a pathway to death. So, it's a super unfortunate occurrence. But yeah, that's what happens.
And compared to like propofol, which is how Michael Jackson died, propofol is a much more dangerous drug. It is very easy to stop people breathing if you give too much. And ketamine is a bizarre agent which you don't stop breathing, which is kind of crazy. Every other drug we use in medicine to sedate you enough to put back your broken arm also has the side effect of potentially making you stop breathing, but not ketamine. It's an amazing drug.
Unless, of course, you're underwater.
Exactly.
Again, with the caveat, like,
or if you've just drunk like 5 gallons of alcohol at the same time, that's also bad for you.
Yeah, I don't mean to make light of it. It's just that's been such a big thing in our, what happened to Matthew Perry. Well, Matthew Perry took way too much ketamine over extended periods of time and then drowned. And so I mean, we have ER docs come through our training program, and one of them just had this famous line, like, we give ketamine like water. We have absolutely zero concerns about, physical effects, but that process of getting into that dose range where you're not sleeping and that you are cognizant of what's coming up, is quite intense. And there's so much richness to be learned from that. So, yeah.
So if I wanted to start a ketamine clinic tomorrow, and I don't, but if I did,
you could. I mean, you have all the qualifications that one needs.
I'm perfectly comfortable using ketamine in large doses to do procedures, but I don't really know how to use it for therapeutics. So where would I go to learn that, and how would I learn that, and how do you find a psychologist to link up with? If you want to be the MD and you want the psychologist and you want to be a team, where do you go to find these people?
Great. So that's a great question. So I would highly recommend that anybody who works with it gets training. This is one of the weird parts about the field. Like, you wouldn't go into a different type of area in medicine without getting training, but you can with ketamine. Like psychedelic medicine is an emerging specialty, just as emergency medicine was an emerging specialty, I don't know, 25 years ago. Is that accurate?
Yeah, probably like 40 years ago.
Yeah. So
20 years
at
ago in
one
some
point,
countries.
right, at one point, emergency medicine was not a particular specialty, and psychedelic medicine is now just considered kind of this like in the medical field, this like thing that you can just go do. And, there are many physicians out there or medical professionals who are prescribers that are making very sweeping claims about that they work with all kinds of mental health issues. And the reality is that ketamine alone can be helpful, but it can also be harmful. And so, the biggest like adverse effect that is reported attached to ketamine is people going into ER for perceived psychosis and psychological effects of high doses of ketamine administered in ketamine clinics or in recreational contexts. So always keeping that caveat in mind. It's physiologically safe, but it is not always psychologically safe. So there's the medical training, and then there's the at least having an awareness of the psychological training. And then I also think that people should get some experience with the medicine themselves. So there are many training programs around, and there are many good ones, but you want to specifically focus on, from the medical side, you need training on the dosing protocols, on understanding of the different routes of administration. So in our training program, there's intranasal, there's sublingual, which is lozenge or troche, there's IV, and there's IM. So understanding the pros and the cons of the different routes of administration and the dosing protocols that go along with that. What are some of the things that you might be watching with patients? What are the different factors that go in with that? So if you're going to be doing, what does go into preparation? What does go into integration? What about set and setting variables? What about the music? Because the music is a huge piece of the experience. So all of those things combine to create the whole experience. And you could do ketamine without a clinical professional. But it's great if you have one. Like in our clinic, we actually do both. And the medical providers kind of make that determination, or they offer it to the clients. As we do more and more ketamine-assisted psychotherapy, we have more and more people asking for it and wanting it. And I think that there's a piece about the medical team over time coming to really understand the benefit of that, because ketamine just started without therapists at all. It came out of the ER. We found people had profound benefits with treatment-resistant depression. Then we layered in a series where we do them more, spread apart to try to extend the benefit. And the latest layering on is the therapist. So it can be done with it. But so there's the medical pieces. We assume medical professionals already have a sense about the physiology and, can learn about the medicine. But how do you dose it? What about set and setting? What about music? What about patient care? What are the things that you need to know? What are the contraindications? How do we refer somebody to that? And then how do you develop a relationship with the clinical professional? How does that work together? And then you can go to a training program like ours, the Living Medicine Institute. You can consult with the professional who's doing that. We have that available. And then there are other programs too that are specific ketamine for physicians. And I would always just say there is this really important understanding for people to know that ketamine therapy ketamine-assisted psychotherapy is one version, and then ketamine treatment or ketamine therapy is another version, and the words are interchangeable. So just because somebody says they're doing ketamine therapy doesn't mean they're working with a therapist. So it's just, we just don't have a lot of standardization of terms. But that patient care, how can we be caring? What is the different lens for diagnosis? How might we engage with them differently than just a patient in a medical clinic? And then how does that impact it? So in our training program, people do, we actually really recommend that people have their own experience with the medicine so they can really understand and be sensitive to that. That is not a widely accepted tenet. Like, some people don't agree with that. I would just kind of raise a question mark, like, why would you want to do this if you're not interested in doing it yourself? Like, it seems logical to me. But, just in summary, there is no requirement. But I believe that there will be. So if you want to start a clinic, like, get in on that, get in on the ground floor, get your training, like, do good work, like, follow that tenet, do no harm. Because if you're doing higher dose and you're just sending people away without any sort of integration, you have no idea about the adverse effects. You're going to hear about the positive effects, but you're not going to hear about the negative effects because people are walking away feeling ashamed, like they did something wrong. They're the weirdo. They had a weird experience. So get your training, get some mentoring, get some supervision, and not just on the medical side, but also exploring the mental health side, the set and setting variables, and all the things that go into good treatment. Because the medical person is an integral part of the team. Obviously, if they're the only member of the team, but even if they're working with a clinical professional, like how the medical person comes in and engages with the client is absolutely critical to the process.
So I have lots of training in ketamine for procedures, but here's a question. I would have no idea which patients would be a good candidate. So who is a good candidate for this type of therapy? And, in similar way, who is not a good candidate for ketamine-assisted therapy?
Let's start with the rule outs because, in the private sector, right, there is just like straight up, let's just own it. There is a piece about who shows up at your door, right? So it's like, who it is effective for is a lot of people like struggling with a range of mental health issues. And always keeping in mind with the caveat with that a lot of treatment-resistant depression is related to PTSD, complex trauma, just like repeated chronic stressors that are often associated with relational issues that can go back to childhood. And that is probably why a lot of those do not respond to SSRIs. Now, that is my bias as a trauma therapist. But just get, with that caveat, because that kind of opens the door to understanding the complexity of people's presenting issues. Just because somebody presents with depression doesn't mean we just remit the depression, because you can also have the depression remit and suddenly a bunch of other stuff emerges because the depression kind of squashes people. Like it's almost like a protective. So, understanding that piece is really, really important. Like at least having an understanding enough of mental health. If you want to work in mental health, you should have some understanding of underlying mental health issues. Recognizing that it's appropriate for a lot of people with a range of presenting issues. Probably treatment-resistant depression is the one that's the most it's the most well-studied, and it seems to remit the fastest, but it's also has a lot of recognition that, a month later, 2 months later, a lot of anxiety can also emerge for people with trauma. The more complex mental health issues that you start to get at, like, chronic and persistent anxiety, worry and rumination, OCD, things like that, at that point, you want to really be considering partnering with the therapist. So I say the more presenting issues and the more complex they appear on the mental health side, the more you want to partner with a mental health person. And then in terms of contraindications, like significant kidney disease or significant kidney issues, and that's because one piece of data around ketamine is that there can be bladder issues with repeated persistent use. And we don't really know exactly what that's about, but you want to monitor that really closely. And we don't want to do harm in that area. But there's something going on with bladders with chronic and persistent use, of which ketamine treatment in a clinic is not that. But we still don't know exactly. So if you want to be really careful, untreated high blood pressure, because people can get anxious during session and their blood pressure can spike. And then we want to look at daily use of benzos, and a couple of the mood stabilizers are not rule outs, but they might diminish the effectiveness. Beyond that, you want to look for, self-harming, kind of impulsive sort of behavioral issues that can be destructive, recognizing that ketamine can also be really helpful with that. But there's always that caveat that for some people, things get worse before they get better. So you really want to assess, does somebody have a social support system? Are they cutting? Are they hurting? Are they excessively drinking? And those are not rule outs, but they're because ketamine can be super helpful with diminishing compulsive behaviors and impulsive behaviors. However, you also don't want somebody to hurt themselves in the process of getting better. So, and then like really persistent personality disorders. And again, does a medical professional have the capacity to assess for that? If somebody appears to be extraordinarily narcissistic, like they continually elevate themselves over and over again to the point where it feels weird even to you, just know there is a relational component to this, and that is likely to show up. So those are beyond that. It again, the big caveat is the more physiologically or psychologically complex somebody appears, then either consult or get additional members on the team or just very much handle with care. And I also really believe in patient education. Like, ketamine can be addictive. Like, don't go seek this out recreationally. Do not go seeking the high, right? Because you can have a ketamine experience that has a big therapeutic impact in a recreational setting, but that's kind of begins to be like chasing the crack cocaine high, right? Mm-hmm. Like, you're not going to get that by consistently using it recreationally. That's just not going to happen. And that is not the same as working with trained professionals in a medical clinic with a specific treatment goal. It's just not the same.
Yeah, so that was one of the questions that I had for you. What do you think about the recreational use of ketamine? And I'm so glad you said that ketamine is addictive, because people are saying that it's not. And I'm like, no, anything that changes your brain can become addictive.
Yeah.
Whether it's exercise, ketamine, heroin, whatever. So all of these things have potential, for addiction. So I see a lot of tech bros right now that are doing ketamine at parties by themselves. And a couple of them, the most prominent of them, appear to be becoming increasingly unstable. And I'm terrified that the ketamine is part of what we're seeing with some of these people who will remain nameless, but are very, very rich.
Oh, undeniably so. Like, and there's a part of me that's almost like, this is just personal, but I'm almost mad. I'm just like, come on, don't get my profession shut down. Like, don't give us a bad name here. Like, don't do that. And that sounds like not compassionate, but it's just like, because people don't know that it's addictive. And, then we get these Matthew Perrys and we get things like that. And then, and then that brings regulatory eyes down who might not know about it. And so that, it's a nuanced kind of thing, but we see that a lot. And what I believe happens is that people are like, oh, this is used in, therapeutic settings. And so, we set ourselves up and we have this profound experience. And so then why not do more of it? We've been using it in the ER, it's safe. And so people begin to use it more and more often at higher and higher doses. And tolerance develops. I've seen that. And then it becomes this chasing the high that is really just like chasing any other high, because I do believe that if you're doing it consecutively, that pretty soon that benefit's going to wear off. And so just the same as any other drug, you use more of it, you use it more frequently, and you're chasing that original, what really probably was a therapeutic experience. And another pathway to addiction that we see more and more is this chasing of spirit, is kind of what I call it. Like, people have a transpersonal experience, and then they start to do more and more and more in an effort to try to kind of go through the portal almost to access that, like as if you are moving towards special powers. Well, that also looks a lot like mania and psychosis.
Yeah, my therapist said the same thing, having a few patients where they wanted to go live in that world forever.
Yes,
and so
exactly.
they were constantly doing the drug to try and live in this place, and they saw themselves as sort of the shaman within that space. But that means, as you said, more and more doses, more and more frequently, just like Matthew Perry was doing towards the end of his life, just truly extraordinarily high doses of the drug.
Yeah. And I would say, if there is anybody out there listening who's like, well, I use it recreationally and I like it. And, okay, then limit it to once a month. Like, like we have patients in the clinic who come in once a month and do ketamine. And so limit it. Don't let the reason that people come in and do 6 sessions over 3 weeks, we call that an infusion series, or for you with 6 sessions over 6 weeks, be a justification for doing it more frequently than that, like, or continuing to do that for many months. We don't know what that's going to do to you. Like, we just don't know. And what I see in people, and I don't see a lot, but I'm tracking this pretty carefully. People, like you said, the tech bros, it makes them kind of methy and strange. Like, it no longer has that like chill dissociative effect. They're like, get kind of twitchy, and you start to see the unraveling. And I don't think it's good.
Right.
So
I got another question about prophylaxis. So I've sort of become to believe, and I'll go back to the ER doc experience, but this is true of any profession where there's an enormous amount of psychological damage going.
Yeah.
I've been telling residents increasingly that I think you should get a therapist the day you start your residency. that you should prophylactically be doing therapy, however often, once a month, more frequent if you've got other issues to deal with, but you should have somebody to talk to. And then I was wondering, should we be doing ketamine prophylactically? Is there any studies out there to suggest that maybe for these high-risk professions that in a therapeutic environment, that maybe psychedelic therapy could be used prophylactically?
Well, I don't know of any studies like that. I mean, we have one particular caveat, which is that, if you're going to stay within the scope of practice and we're going to stay within FDA approval, people have to have a diagnosis to be able to have it be utilized, because it's not technically okayed for therapeutic use. It is okayed for off-label use for mental health issues. So that kind of puts us in a particular lane. Now, people stretch out of that lane a lot, but like wellness retreats and leadership retreats and things like that, unless people are, if you're going to follow those, specific to stick with that, people have to say that they have a mental health diagnosis. Now, any high functioning professional who's experiencing burnout and chronic stress would certainly qualify for either depression, depressive disorder not otherwise specified, or anxiety disorder not otherwise specified. And so, but people have to be willing to do that. Again, you can stretch that if you want. That depends on your own personal level of risk tolerance. But there is a study recently that came out, and I think it was in JAMA, that talked about ketamine reducing burnout in medical professionals. So there is actually data to support that. And then there is a group, Phil Wolfson is one of the pioneers in the field. And his group has come up with an acute stress protocol, which is actually low dose ketamine in a group context. And I think individual and or group. And that's low, like 25 milligrams, to help when people are in more of an acute stress situation, to help with nervous system. And I think it's what happens with the neuroplasticity and the fact that your brain changes and your nervous system kind of reprograms itself, ideally in a relational context, therapy or other relational context, so that you can move into neutrality or contentment as being your default state instead of chronic stress. It kind of like stops the stress response and helps you get back to a more baseline. So I don't know that it is being done, but I would 100% get behind it. I would get behind a research effort. I think that it could make fabulous sense. There is a company called Enthea that I actually did a podcast with their founder, where they're actually working with private companies to allow ketamine as an employee, as like an EAP, employee assistant benefit. For exactly that reason. Like give your employees this benefit. It's underneath mental health, but it can certainly be used in that prophylactic kind of way. Like, it would be amazing if medical professionals, and really any professionals, recognized before they got to that point that living in a state of chronic stress is actually not healthy.
Yeah, that's the place where I'm really thinking about it. Being in a relationship with a therapist so that you can recognize when you've passed some particular threshold and then maybe do ketamine therapy. What's fascinating to me is my professors, so I'm 60, all my professors are in their early 80s now. Yeah. And almost to a man and woman, they were the kids of the 60s, and they did psychedelics during the 60s. And I haven't found one of them, I haven't found one of them that says that was bad. They all credit some of their, or much of their success to the fact that that was a thing that they did in the 60s. Now, we probably don't hear from the ones who became addicted and fell out of society and these are high functioning. But it seems like we then went through this 40-year period where you can't talk about it, you can't research it, you can't think about it, and it kind of went away. And now we're back to where we were in the late 60s, where we're studying it. We're trying to think about how that we could best use this. But I feel like we've gone through this period of time where the people with experience of this are now in their 80s.
Totally. And it's super interesting because a lot of the kind of leaders in the psychedelic field have essentially jumped ship from like mindfulness or trauma or other areas. And as it's become more okay to speak openly, like we still only have pockets of legality. Always keeping in mind, everybody, like ketamine's never been illegal. Like it's 100% legal. It's never been illegal. Like you can't just veer off and use it however you want, but it's not. But the others are and have been, except in small pockets. And, many of them saying like, oh yeah, psychedelics informed my, mindfulness practice. Ketamine, psychedelics informed my compassion practice. Like one of my, there are a number of people whose work I follow that have kind of jumped ship in it exactly that way. Not only was it not bad, it was profoundly helpful in shifting their consciousness and, expanding their intellectual interests and curiosities and maybe even capacity in ways that really furthered their careers. So I'd like to remove the stigma from mental health and psychedelics, and then certainly any stigma about blending them, because we all could, I'm not saying therefore everybody should go trip. I'm saying in intentional ways, used for intentional reasons, that these medicines can be super helpful for people.
So you're not saying remove the fluoride and put the ketamine in the water?
I am not. And I'm also not saying like broad legalization. I'm saying that, let's pay attention to the intentional use of psychedelics for, addressing entrenched mental health issues, really such as your own, like that you spoke of.
So what about, so LSD is illegal. Psilocybin is illegal outside of trials. Where are we with new molecular weight and old molecular weight entities in addition to ketamine? Because a lot of experts I speak to say, of all of the drugs, ketamine isn't really the best. We've got much better drugs we could be using. So where are we with those other medications?
Well, let me first just say, I'm not convinced that other drugs are better. So just that caveat, like ketamine fits into a clinical practice really well. If you put consecutive sessions like you had, along with a trained therapist, I'm not certain that the data would show that psilocybin or LSD or MDMA is better. I'm not. It remains an open question mark. So, ketamine has a lot of properties actually that are much like MDMA when done in a relational context. So separate conversation, but I want to just make that caveat, because I actually got into this thinking that the people that I work with and train with were in line to do MDMA psychotherapy. And I was like, sweet, I'll just do this ketamine like while I wait for that. And then I've come to really appreciate it. So where we stand with all of those things, MDMA this summer in August was turned down for approval by the FDA for therapeutic use after 20 some years of research that the FDA was involved in. This is, I'm just going to come out and say it. Like, the FDA got involved in the research. They coached the research. They supported the research. They participated in research design. And there were multiple trials, stage 3 clinical trials, exceptionally well designed from a psychotherapy outcome research perspective. And at the end, after all of that, then they didn't approve it. So it's mysterious. They have not made public the reasons why. It looks like there's going to need to be another round of clinical trials where they follow some specific guidelines. But given what you said about SSRIs getting only like 50% efficacy and having all these side effects, that just seems weird, because the adverse effects reports were actually very low, and the reports of lasting and profound effects on PTSD symptoms were unheard of. So that's still in the works. And I think the state of Utah has okayed it, oddly. Like, you think of Utah as a conservative state, but Utah also okayed it, use for therapeutic use. I don't know how that's going. Australia has approved it. The Netherlands has approved it. So we're going to kind of see how that goes. Will it follow the cannabis route where states are going to begin to approve it? We'll wait and see. Psilocybin has some really super promising research in a lot of domains. And there are pockets where it's been decriminalized or made legal. Oregon, the state of Oregon, you can go to designated centers with designated providers, and they license providers, they license suppliers, and they license centers. So you can actually go there and utilize psilocybin for therapeutic use. Colorado has also done the same. They started with decriminalization, so you weren't going to get arrested or prosecuted. And they either have moved towards or are moving towards full opening for therapeutics. And their laws are looser than Oregon's in terms of having to be certified providers and things like that. So it'll be interesting to watch. There are counties in various states, like there's a county in Michigan where it's decriminalized. There was a reason on the ballot for I think psilocybin in Massachusetts that didn't pass. So there's a lot going on. LSD has gotten off of like no one ever can utilize it ever, ever, ever in the history of the world to being given, I forget what the status is, like very promising treatment status for generalized anxiety disorder. So it can be researched under extraordinarily controlled conditions. There's a race in big pharma to make analogs of these things that can come out and kind of bypass these things. So we're probably going to see some of those analogs. It's a super interesting policy landscape to follow. So
yeah, there's a lot of work being done on trying to find which part of the molecule has the therapeutic effect, and is it different from the psychological effect, the trip. And I've heard some of your colleagues argue about. I think that experience is at least important as any other part of the molecule. So to divide them out, well, it'll take us years to find out. Maybe it's just this tiny piece of the psilocybin, and then there is no trip that goes with it, and you'll still feel better. And maybe the two will always go together. I don't know. But I know that there's a lot of interest in the pharmaceutical industry into this right now.
For sure. Well, and what we talk about in our clinic kind of as part of our, initial client intake process, or, when a new client calls, is it's really a three-part. This comes from Dr. Maydad Goldman, who runs the clinic. It's a three-part stool. There's the pharmacological effect. There's the experiential effect, which is what you go through in your own internal landscape, and what you come out with. And then and those two things in and of themselves are quite profound. And then if you add in a therapist or a clinical, therapeutic component, then you've also got the psychotherapy effect. So I think at good clinics, we're trying to weave together all of those different pieces to really maximize our outcomes, to create the optimal conditions for clients to have profound and lasting effects. So, can you take any one of those pieces out and kind of, I don't know. Certainly we know there are pharmacological effects, but what we don't know then is what happens when you only isolate that and you don't have the experiential part or the therapeutic part. So.
Yeah, I can say for me, the experience part really set, I think, myself up psychologically, like something strange and weird and hopeful is occurring here. And that was an important part of the therapy for me. So I can't imagine it being as effective, but we'll see.
Yeah. I just have another question I'd love to ask you, just if we could, just about what do you see, having been a person who has experienced this, being a medical professional, working in a profession that has access to this and could do this, what is the potential and how do we make this as effective as possible? I know based on my experience and my review of the research and training and doing it clinically, that this can be extraordinarily potent and effective. I know that it doesn't work for everybody. And I also know that people can have adverse outcomes. And yet people can have really life-changing experiences that set them on a different path. So, what are your thoughts from your, side of the fence here? How do we do this as effectively as possible? And what is the potential?
Well, I think, first of all, we have to destigmatize mental health. We've been trying to do that for a few decades. We've still got some work to do there.
Yeah.
We now need to destigmatize novel therapies, because the non-novel therapies sometimes work, sometimes don't, and it's their effectiveness is not so great. So I have great hope for these therapies, and the initial studies are really positive. And but I think the way we move this forward in the medical field is by more research.
Yeah.
More research, more research, more research. Let's work out the exact protocols. I mean, when we first started to do this, it was basically people in the ER pushing ketamine. Somebody who had a dislocated shoulder who was depressed. The shoulder got put back in. That was easy. And then they're like, I've never felt this good in months, years. And
It turns out I'm not suicidal. Right.
But then it would wear off if you just did it once. And so we still, I think, have to work out the protocols, the dosing, all of this stuff. And that takes years. But in the meantime, it's offering an enormous amount of relief to a lot of people. And we should not be afraid of it. This is an extraordinarily safe drug given under the right circumstances. And so I just think we should be doing what we're doing right now, Sandy. Getting the message out and going on podcasts and writing books and doing all these things and destigmatizing this, while at the same time doing that research, which is expensive and takes a long time, to help us guide where we should go in the future. But we should be doing this now. If you've failed therapies, other therapies for your depression, anxiety, PTSD, you absolutely should go and consider this therapy. For me, life-saving.
Yeah, I love that. Well, I'm really appreciative of your time. Thank you so much. This has been phenomenal, and I'm very grateful. And thank you so much for sharing your personal story as well as your professional expertise. I think people really need to hear that. And thank you so much.
Thank you, Sandy.
Thanks for listening to Living Medicine. We'll see you again next time. Be sure to click subscribe to get future episodes.